Welcome to the ANEW Insight Podcast, empowering and inspiring your journey to optimal health. Hosted by Dr. Supatra Tovar, clinical psychologist, registered dietitian, fitness expert, and author of Deprogrammed Diet Culture. Rethink your relationship with food, heal your mind, and live a diet-free life. And Chantal Donnelly, physical therapist and author of Settled, How to Find Calm in a Stress-Inducing World. Here at City Club Los Angeles, we follow our guests' journey to optimal health, providing you with the keys to unlock your own wellness path. Tune in and evolve with us. Hello and welcome to the ANEW Insight Podcast. I am Dr. Supatra Tovar, and I am thrilled to have board-certified urologist Dr. Jeff Loh-Doyle with us today. Welcome, Dr. Jeff.
Thanks so much for having me.
Yay. Well, I am going to read a little bit about Dr. Jeff, and then we will get right into our questions. Dr. Jeff Loh-Doyle is a board-certified urologist at Keck Medicine of USC, specializing in male sexual health, particularly erectile dysfunction, or otherwise known as ED. With a passion for improving men's health, Dr. Loh-Doyle combines clinical expertise with compassionate care, helping patients navigate the complexities of urological disorders. He completed his medical education at USC, followed by residency training that solidified his commitment to urology. Dr. Loh-Doyle is dedicated to advancing research in male sexual health, aiming to destigmatize discussions around ED and provide effective, personalized treatment options for his patients. Welcome, Dr. Jeff.
Thank you so much, and it's really a pleasure being on here. And I commend you on this podcast for really bringing in multiple different specialties, because as we'll discuss today, ED is not just surgery, it's not just medications, it's about overall health.
Yes.
And I'm really excited to talk about it.
Me too. So first question, why penises? Just kidding. No,
yeah.
What inspired you to specialize in urology, especially men's sexual health?
So I think as many urologists can attest, they truly don't really set out being a urologist as their lifelong dream from childhood. In reality, you only learn about urology probably through medical school.
Yeah.
But what's really interesting is that when you're deciding what you want to be, when you're practicing medicine, you have to rotate with different specialties. And oftentimes what we realize as urologists is that we will somehow get exposed to urology, but then we get exposed to the personalities, not just of the urologists, but also of the nurses and all the other staff helping, but also the patients. And we also just then realize, all right, are these the type of people that we want to work with, but also take care of? And oftentimes we find that urologists are known as the happy surgeons. I mean, they're known as having a great sense of humor. They have a good quality of life because we take care of really complex, sensitive issues. So you can't really take yourself too seriously. So we identify with people that we really feel that have very like-minded, and that's where we kind of decide, all right, do we want to follow that specialty? And then you kind of come to find out that urology is awesome. I mean, it's just a great field. It has a huge breadth. You can do surgery. You can do a lot of procedures. You can really choose what type of urology you want to practice. And also, selfishly, there's not many of us, so we're always busy, so we can really choose what we want to do. So a lot of us have practices that we really hone in on specific diagnoses that we really are passionate about.
Right. So for you, the passion lies where?
So I take care of men and issues that arise either because of other comorbidities or specifically because of cancer therapies.
Right.
So I take care of the after effects of prostate cancer therapy. And we know that prostate cancer is the number one solid organ in men. And so there's a lot of patients out there, and there's a huge unmet need of taking care of patients that have erectile dysfunction, incontinence. And I also take care of patients that have really bad scar tissue that forms after radiation therapy as well as cancer therapies. So I'm very much about treating quality of life. I'm not necessarily a cancer surgeon, but I take care of the after effects and consequences of cancer therapies.
Wow. And I would really love to know what actually inspired you to become a doctor in the first place.
So I always loved working with my hands. So when I was young, I would always help my dad in the yard. He would help with him with yard work. My dad was an engineer. But I was always doing connects. I was doing Legos ever since I was really young. And I just felt that working with my hands was really fun. At first, I wanted to be an orthodontist, and then I transitioned probably through my teenage years, and I wanted to be a surgeon. So I didn't know what type of surgeon I wanted to be. Initially, I thought I wanted to be a plastic surgeon, and then I kind of pivoted towards urology. Turns out, though, I married a plastic surgeon, so I really realized that I made the absolute right choice because plastic surgeons are a little bit different than urologists in terms of their personality. And I identify way more with urologists. But very much what I do now in urology is very much the plastic surgery combined with urology. So we do a lot of reconstructions as well. But from a young age, I really wanted to be a doctor and specifically a surgeon.
Wow. Well, you specialize in erectile dysfunction, among other things. Can you explain to our audience? I think a lot of people actually have a lot of misconceptions about erectile dysfunction. How is that its own condition as opposed to having maybe difficulties in just achieving an erection?
Well, how we define erectile dysfunction is either the failure to attain or maintain an erection that's satisfactory for sexual pleasure or performance. Okay. So that's very much defined by the patient. So just because someone doesn't have a strong erection doesn't mean that they're not happy. And vice versa. You can have a patient that has a quote-unquote strong erection that's unhappy. So that'd be defined as having dysfunction, and specifically erectile dysfunction. So that's where it comes into a conversation that we have to have with the patient. We have to break those barriers down, and we have to identify, all right, specifically where can we make things better? Where do you feel like things are not quite where they want to be?
What do you mean by they're not happy?
So it's very much dependent on patients. I mean, in this day and age, there's a lot of exposure to social media. There's a lot of pressure on patients to perform in some way. And so even though we may feel that they're performing just fine, they may not feel that way. So we really have to identify, all right, where can we do better and where can we make you happier, whether yourself or in a relationship or with your partner, because all those things matter.
Right. Would you say that there's a lot of pressure because of porn?
Huge. So one of the largest patient populations that we see is younger patients. Wow. And the younger patient that's very physically fit, they have no other comorbidities, and when you really ask them, all right, so how much pornography do you watch? And they say, well, doctor, I watch every day. I'm like, okay, how often do you watch? About an hour. And how often are you masturbating? 3 or 4 times a day. So I don't know about many men out there that can maintain a strong erection if they're masturbating 4 times a day. But then you actually have to figure out, all right, how can we undo that obsession? Because when you actually ask a patient, why do you do this? I mean, they're actually not watching it for pleasure. They're actually watching it as a way of an outlet of stress. So it's actually stress relief. It's actually not for pleasure. So if you've now converted something that should be pleasurable into something that it's done to release anxiety or stress, you've now created a little bit of a different paradoxical scenario where, we all assume that an erection is for pleasure, but it's actually someone's getting an erection and then masturbating more to kind of satisfy something else or to at least get rid of or at least block out something mentally. I mean, now you've undone something.
Yes. And I mean, certainly boys are becoming more and more inundated with porn, especially with having, access to devices.
Yep.
Would you say that erectile dysfunction has shifted to younger generations because of that primarily?
No, I think we're just seeing more of it. I think that it's always been an issue. I think that, performance anxiety has always been an issue no matter how old that patient is. No matter how old someone is, you can still have anxiety over that. But I think that what it has done is that it's taken it out of, it's been destigmatized a bit. Right. Where now we know that, younger patients are susceptible to this and even older patients. But I think there's now more and more patients knowing that, all right, I can't necessarily just ignore this. I mean, this is a problem and it's affecting relationships. So we see more of it now because I think that as urologists, we're doing a better job of talking about it.
Oh, I would agree. But I also do wonder the medium in which they're receiving porn is different, say, since the 70s or the 80s.
Oh, you
when
had
it
to go
might have been-
sneak into like a supermarket or your dad's closet to go find it. I mean, now you can just Google something and get it on your phone and
Right.
get it immediately.
Do you think the phones have anything to do with contributing to
Probably.
ED?
Yeah. I mean, I would say that, there's a lot of other outlets besides pornography. I mean, there's ways in which that people interact now with, there's things such as OnlyFans and other subscriber options. I mean, it very much eliminates the interpersonal connection that someone has with having an in-person talk with someone. I mean, people pay to interact with someone just over the phone.
Yeah.
And it's not necessarily just about, seeing a picture or seeing a video. But you actually find out what people are paying for. It's actually to talk. So it's very, that's what's unique, is that it's not just about a visual stimulus. It's actually a conversation. And so it's really, really complex. But we know that that people now have less social interactions. They're a little bit more lonely. And, how is that going to kind of, and these are younger people. I mean, I have, my wife has younger female friends. They're single. And they say that the younger generation of men don't know how to interact with them. They don't know how to talk to them. They don't know how to flirt. They don't, quote unquote, have game.
Wow.
So, I mean, this is a problem for society. And so is this contributing to ED? Yeah, but it's contributing to a bigger issue of just overall, dysfunction in interaction between people.
Right. And I'm sure the pandemic didn't help things
No,
at all.
it did not.
Did you see an uptick in ED with the pandemic?
Not necessarily. I mean, I think that, the way that my practice is built, it's at a cancer center. So I'd say a large proportion of my patients are post-prostatectomy or post-cancer therapy. But, there's still a very steady stream of young patients that come see me from, local colleges that have issues. But it's been pretty consistent because we know that accessibility to pornography has been pretty stable over the past decade or so.
Oh, yeah, definitely. Well, I'm sure there was an uptick in it, but maybe it's not necessarily seen right away, right now. But can you tell us what are some of the most common misconceptions about erectile dysfunction, especially the kinds that you encounter in your practice?
Yeah, so, everyone thinks that ED is somehow, it represents less of being a man, or that it's somehow just caused strictly because the plumbing is bad. But we know that having an erection and being satisfied is very much a combination of different things. I mean, you have to be anatomically, physiologically, and mentally able to have those things. All three have to be clicking simultaneously. If one thing is not working, you're going to have a problem. And so, it's not just a fixable thing with medications. We know that, it's a complex interaction of things that creates a strong erection, or at least a meaningful erection, and you have to treat it in a multifaceted way.
So what do you think is the most common misconception? That it's all in somebody's head? That it's, just because of diet or lifestyle?
No, that erectile dysfunction only affects older people. I mean, as we talked about earlier, I mean, it affects men of all ages. And so very much it's about destigmatizing and talking and telling patients, you got to talk to someone about this because it could represent a lot of things. So that's the biggest, that's just confined to an older patient.
But there must be a lot of shame.
Absolutely.
And, just an inability to talk, to, seek help. How do you suggest people overcome that?
Well, if you're a younger patient, where do you seek out? I mean, are you going to go online? Are you going to talk to your regular doctor? Many patients today, especially male patients, don't have doctors. So who's going to be that person? And so oftentimes, as a urologist, especially, we're the first doctor that a patient or that a guy has seen. And so when we see a patient, especially let's say in their mid-30s or 40s, sometimes it's not just attributable to performance anxiety. I mean, it could be because of a cardiovascular issue. So we have to be we have to put our doctor hats on, and we have to say, well, let's look at their labs, look at their cholesterol, let's look at their lipids, let's look at their blood pressure, let's look at their blood sugars. And sometimes we diagnose all these issues, and then we say, all right, cool, we can fix your erections, but there's other issues going on here. You need to see or establish care with a regular doctor.
Are you seeing those kinds of issues in younger patients today?
Well, I think that with COVID, we know that patients are not exercising. They're not eating as well as they used to. Foods themselves are more processed. And so just overall, we know that overall health correlates with erections. And poorer health means erections are not going to be as good. So we're seeing patients now that just don't, they come in, they never work out, they don't exercise, they're overweight, and they wonder why their erections aren't bad. Well, there's really no mystery behind that.
Right. Do you see that it's most common with people who are overweight, or is it?
It's all over the place. I mean, you'd be very surprised. You may have a guy that's very fit, that, is in a very stable relationship, has a meaningful relationship, and then he just has bad luck. Erections just aren't quite there. And then you can have someone that, you would think that, they have diabetes, they have poor blood pressure, and they got strong erections. And you're like, so it's not just those things. I mean, that's where it's really a combination of things to create, a strong erection, or at least one that someone's happy with.
Right. Well, being a psychologist myself, this is a very, a question that's very close to my work. What are some of the psychological factors that contribute to ED? Depression,
anxiety, feeling like you're not quite, meeting the expectations of society. There's shame. There's some issues with patients that have religious beliefs. So as a urologist or anyone kind of talking to a patient that has ED, you have to kind of dive deep into those issues. And I commend you in your work because us as urologists, we're good at prescribing medication. We're good at doing surgery. We're not really good at diving deep into someone's psychological experience. But we know that it's extremely important. And there's been numerous studies to show that if you were to compare patients that just get medication and you compare those to patients that have medication plus the role of a psychologist or a sexologist, those patients do much better.
Right.
And if you involve the couple, it's even better.
Right.
So it's your field, they're vital in the treatment of erectile dysfunction.
Do you assess for that? How do you do that?
So we ask a patient, we'll ask them, do you feel, it's very much dependent on their description of their erection and where they're having dysfunction. You may have someone say, well, doctor, I've got strong morning wood. I get great morning erections, nighttime erections. But, when I'm on my third Tinder date, I'm not having great erections. Okay, well, is it because you're not necessarily in a stable relationship and you're kind of dating around and you're always trying to be the best? And maybe you're having it with maybe a drink or two on that date. So we have to kind of ask the situational relationship of erections. We have to understand where the erections are good and where they're bad. I mean, if they have a great erection when they're doing masturbation, that means that the plumbing is good. That means that the mechanics are good. If they're having that nighttime erection, that means that the physiological machinery is good. But if they just don't get a good erection when they're with a new partner, well, there's a pretty obvious answer as to what's going on. It's situational. So we have to dive deep into that.
Right. How much do you think culture, say things like diet culture or, exposure on social media plays into those psychological factors? Are they comparing themselves? Are they worried that they don't stack up?
Yeah, I mean, I think that there's a lot of guys that feel like they have a small penis and that they just don't last as long as they should, and they're watching, pornography or whatever they perceive to be something that's quote unquote normal. I mean, it's not normal what you see online. I mean, for the most part, it's very abnormal. And so our job, and we do sometimes counsel patients, is to say, look, this is like not normal. What you're describing is normal. And, it's okay. It's okay to be normal because, there's a big spectrum of normal. So we have a lot of patients that come in and say, doc, is my penis too small? And I'm like, sir, I've seen 10 penises today. and yours is just fine.
Yes.
Yours is absolutely fine.
Yes.
Then we talk about average sizes and all those things, but it's all about providing reassurance. And I think that the patients do get some relief from that.
Yes. And I do think that what they're consuming as far as porn has become more and more violent. We had someone who specializes in helping people with, sexual issues, and said that there's so many porn sites that promote violence against women and choking.
Yep.
Do you think that that also plays a part in,
Yeah,
men when they're going to have regular sex?
Yeah, they don't quote unquote have that pleasure. Maybe they require a higher and higher threshold of things that would quote unquote make them, sexually, excited. And so that's not normal, right? And so then then at what point do they feel like, all right, I'm satisfied? And maybe they were just trying to achieve or get something that just is not realistic.
Well, let's talk about some treatments. We're going to get into this a little bit more into the next section. But give us kind of an idea of how you would treat erectile dysfunction, all the different arrays.
So when we see a patient that has erectile dysfunction, and after we pinpoint exactly what that cause may be, so it's very much a shared decision-making model. So we discuss all options, and we give the patient the best options that we'll put all options on the table, and everything's acceptable. And so, for years, everyone thought you had to go through a very stepwise, algorithmic type of treatment. And for the most part, I think that most people do follow that. But we do have some patients that come and say, I want the most invasive thing because I want to be fixed immediately. And that's okay, because there are some patients where that's acceptable. You don't necessarily have to go through things to prove that they won't work to get to an inevitable successful treatment option. And so, our job is to counsel patients on risks, benefits of everything. And it's very much up to the patient to decide where they want to go with that.
Well, you just said the most invasive option, and that got me curious. What is that?
So it's the penile prosthesis. So it's been around for 40, 50 years now, and there's different variations of it. But, what I specialize in is the inflatable penile implant. Just a great piece of engineering. And now one of the major companies of this device is actually trying to destigmatize what a penile implant is. So last year they actually produced a direct-to-consumer marketing documentary which documents patients, couples, and their journey towards getting a penile implant.
Wow.
And it's a very tried and true treatment option. It's not without risk, but there are some patients that really benefit from it, and it really changes their lives.
Well, can you give us a little bit more detail about what that might involve? I can imagine there's a lot of people cringing at home and thinking, oh my gosh,
so
you're going to cut into it. What?
Yeah, so in general, the surgery itself takes about 30 or 40 minutes.
Wow.
It's outpatient surgery, and it's done through a very small cut, either above the base of the penis or at the junction between the scrotum and the penis, so just on the skin itself. There's no visible cuts on the penis. And through that incision, you place 2 inflatable cylinders that get placed inside the actual penile tissues. Attached to those inflatable cylinders is a pump and then a reservoir. So that is the gold standard 3-piece device. And how you get an erection is you will transfer water, which is in the reservoir, into the cylinders by squeezing the pump that we place in your scrotal sac. So the skin itself is very much like in the skin on the back of our elbows. Very loose, insensate. It's just skin. That's all it is. So you can place pumps in there that are really easy to access. And then, obviously, you have to heal from this operation. You come back in about 2 to 4 weeks, depending on who the surgeon is, and they start teaching you how to use it. And then after that, once you feel comfortable using it, you're off to the races. So, God bless insurance. For the most part, this is covered by insurance. And this is very much a quality of life restorative treatment option.
Whoa. Is pleasure the same?
Absolutely. So I don't have a penile implant myself, but I've been told that patients themselves feel like it's as close to what a normal erection would be like. It's not the same, but you should still be able to experience orgasm and sensation.
that is, I think, a good question to add on to that. What if they do have difficulty with orgasm? They get the penile implant. Does that actually contribute to a better orgasm or having an orgasm?
It may, yeah. So we don't guarantee that, but there are some patients out there that have anorgasmia or dysorgasmia because they just cannot, have a satisfactory erection. They feel like, with a soft erection, they just can't quite get to that climax point because mostly they're probably embarrassed or they're concerned about how their partner feels about them. But what's interesting is that patients that have their prostates taken out, and some of these folks don't have erections. They can still get into climax easily.
Wow.
So having an erection doesn't necessarily guarantee orgasm, and you can have an orgasm without having an erection, which is really interesting. That's a really interesting concept, right?
I didn't know
But
that.
a lot of patients only realize that after their erections are gone, especially after cancer therapy, and they're like, Doc, my wife can still give me oral pleasure and I can still orgasm, but I have a soft erection. I've got nothing. So that's what we try and counsel patients too, is that there's still other ways of having pleasure. Not necessarily need a hard erection. But the penile implant gives you that ability. And the nice thing too for the partner is that the erection lasts as long as you want it to.
Wow.
So 1 minute, 5 minutes, 30 minutes, whatever, you can decide. You can already have your orgasm, but the erection will still keep going.
Wow. So the wife's got the timer. She's like, yep, I've got 5 minutes.
Yep, exactly. Let's go. Yep.
Wow. Okay. Well, we're out of time for this half of this episode, but this is fascinating to me, and I'm sure it's fascinating to you. We will be coming back for the second half of this amazing episode with Dr. Jeff, and we really hope you join us next time. Thank you so much for joining us. Thanks for tuning into the ANEW Body Insight Podcast. Please remember, the content shared on this podcast is for entertainment purposes only and does not constitute medical advice. You can find us anywhere podcasts are streaming, on YouTube at my.anew.insight and at anew-insight.com under the ANEW Body Insight Podcast tab. Follow us on our socials at my.anew.insight on Facebook, Instagram, TikTok, and Threads for more updates. Tune in next time and evolve with us.